And we are live. Hey, everybody, how are you doing today?
I'm great. How are y'all doing?
Good, excited, very, very excited. And everybody on LinkedIn, we are really grateful and thank you for joining. Today's going to be really exciting, talking about the governance of AI within healthcare. And I have some great health care leaders with me today who's going to help demystify and unpack some of the things that's going on with AI governance in the healthcare space. So today we're going to talk about the Coalition for Health AI, or also known as CHIVE. And their whole mission is to advance the responsible development, deployment, and oversight of AI within healthcare. So within the recent few weeks, I believe 2 weeks ago, they released a what they call the transparency report, and my mind was blown. To be quite honest, and I've said this story in one of my LinkedIn posts, but it happened on a Sunday, and I just nerded out and went through the report, and I mean, I was just my mind was blown. And essentially, within the report, there have been 250 bills that have been introduced local on the state level. Some bills have passed, some bills are still in review, and some have been rejected. But there's some really interesting information in terms of governance on what states are looking for. Some are, in my opinion, are overreach. Some are definitely needed. But you're going to hear from myself, but mostly our experts today who've had 20 and 30 years experience in the healthcare space. And to get started, I'm going to make a few introductions. So today we have Chris Grasso joining us. She is the CTO, principal CTO and founder of FastX Partners. Chris has spent 30 years in tech leadership roles for federally qualified health centers. So a wealth full of knowledge there. I'm also joined by Lisa Taheda today as well. She knows why she tripped me up. That's why she's laughing. But Lisa has spent 20 years within the health care space. She's an expert in clinical innovation and population health, focused on scaling value based care programs. And finally, I'm joined with Tanya Zucchini. She's also a member of CHI and has over 20 years experience within healthcare, within strategy and operational optimization. And just to let everybody know, we're in no shape or form representing or speaking on behalf of CHI. We've just looked at the report and are going to share our thoughts and opinions with everybody who joins today. Welcome, everybody, once again.
Awesome. Great. Thanks, Larry.
So, yeah, absolutely. So, starting off, we're going to jump right into it. It looks like with the bills, the 250 bills, most states are really have there's a lot of activity around utilization reviews and prior authorization that are that's prohibiting AI only denials and mandating clinician oversight. From what I've heard, is a lot of these denials aren't warranted. They're not being reviewed right, and essentially they're not fair. So this first question is for you, Tanya. Do you think too many insurance are relying solely on AI denials, and do you think that denials are justified? What are your thoughts?
That's quite a heavy question to lead off with, Larry. Thank you for dropping that right in. I'm not going to give you a simple yes or no. That would be too easy. I don't. I don't know that there are too many insurers using AI only as opposed to AI plus a human in the loop. What I do know is that this report from Chai and our interest in it is around transparency. And we know that transparency supports trust. And we know there's not a lot of trust in AI writ large yet. So I would say that the insurers who are taking a careful and considered approach, and I have seen it done,
Mhm.
and I have seen it work incredibly well, they are going to have fewer AI only activities. I also know that AI is largely used to replace tasks, and a lot of the tasks affiliated with utilization review or utilization management are going to be tasks that can be automated or easily productionalized, which is where a lot of the benefits to be gained are had. So I'm not going to give you an easy yes or no. I don't know what the absolutes were. If you gave me a number and told me how many, I would say, oh, that kind of sounds high, or maybe that's about right. But I think it's really in how they approach the strategy. Lisa or Chris, I don't know if you have a different view on that, but that's where I would leave that response.
Yeah, Lisa, I would like to hear your opinions on this as well. Do you think that with the AI denials and utilization, should there be a human in the loop, or is it okay to solely rely on the AI outcomes?
Yeah, I think, piggybacking off of what you already said, Tanya, there is certainly an opportunity to use tools to create efficiencies. And so I think from my perspective as a clinician, when the criteria are clearly met to approve a prior auth, that's a great opportunity to use tools like that. I think when it's not clear and it needs further review, that's where a human in the loop is essential. As I was looking at these bills and doing a little bit of a deeper dive into it, I did find that a lot of health plans are kind of pulling back in terms of, maybe they started using these tools and the outcomes and the data really created attention in a very negative way, right? So there was a large health plan who will remain nameless that in 2023 a lawsuit looked at their denials, and 90% of their denials were overturned on appeal.
Wow.
Right.
Wow.
90%.
Yeah.
There was something else in 2024 that did a deeper dive into across multiple health plans, specifically around Medicare Advantage. And during the period that these plans were using AI only, the denial rates for services rose significantly. So I think, that really colors in the picture of that. Yes, there's an opportunity to use tools, but we do need to use them judiciously. And when it's not a clear-cut yes, I think we need to have a deeper clinical review.
Christy, do you want to weigh in?
Yeah, no, I think Tanya Lisa accurately described it. We were talking with a AI software vendor yesterday, and he was talking about how insurers were using this as a way to deny claims, and he was interested in having a product on the provider side that would sort of counter it, like an AI product that would counter their AI. And it was funny. I mentioned in the call yesterday, I had this image of this King Kong versus Godzilla match, right? Like going down between these two AI products, duking it out. But anyway, nothing more to add. Nothing more to add beyond that.
Yeah, that I could see how that could, you had the hamster roll going on by everybody, people fighting back. That's pretty funny. Something else that was pretty interesting in the report. At least 6 states explicitly banned determinations based solely on group data sets. The whole bias thing with AI, that sort of thing, and I'm sure people, companies don't really have a tight grasp over that yet. Others are incorporating national standards such as NIST, or requiring developers and deployers. By the way, when I say developers, that means health tech companies, and when we say deployers, we're talking about health systems. So they're requiring developers and deployers to implement risk frameworks, validation protocols, and bias testing documentation. What I thought was so interesting, coming from the cybersecurity realm, is that some of these, when state legislators are breaking this up into risk frameworks, validation protocols, and bias testing, really, that's all within the governance framework. So that's one of the first things that came to mind. So for healthcare, this means compliance might have a slightly different interpretation of what responsible AI means. Meaning, some states think validation controls is enough. Some are thinking a NIST framework or some AI governance framework is what you want to do. So it seems like everybody's on different pages in terms of what governance actually looks like. So my question is, and this is to you, Tanya, is this lack of expertise from policy makers? Is it a pure lack of expertise in understanding, the differentiators, or, understanding that validation, bias testing, and frameworks are essentially all within the same? And if it is, how do we fix it and create consistency across the states?
So I think, Larry, it's not all due to policymaker expertise or lack thereof. And while certainly a lot of the concerns that are raised, and the very valid concerns that are raised, do fall under a compliance or regulatory umbrella, I don't think that that is exclusively the realm of our policymakers to address it. I mean, we know historically in healthcare that insurers and policymakers tend to set the guardrails because we don't tend to police ourselves, as the phrase goes.
Right.
I
Oh, no,
do
no.
think that this really ties back into the first question and Lisa's response. We have to remember that AI is based on data. And data have to be reliable and unbiased and all of the many things that they should be. It should be. And that requires the human in the loop at the very beginning of the process. But you also have to understand that throughout the entire process, those data have to be reviewed and revised. And I won't go into discussion necessarily yet about deterministic versus probabilistic use of AI, but I think that's an important consideration. I will say that in reviewing this particular report, it was interesting to me that, to your point, Larry, while most states agree that something should be done and action should be taken, and therefore 250 bills across 46 states have been advanced, the details of how, as you said, have not been agreed upon. So everyone agrees on a kind of set of foundations or guidelines, but the implementation of those tends to vary somewhat regionally. In terms of how we can fix whatever the problem is, if it were as easy as fixing expertise for policymakers, if that were an easy task, that could be done. I think it's more broad, and I think it's like many of the challenges that we have in healthcare. You have to start by identifying what the issue is. You have to figure out what's most important to you and your role that you play in the ecosystem, whether you are a payer or provider or patient or policymaker. And that's where the differences come in, whether they be regional or by stakeholder or what have you. Once you know what the challenges are, and I think a lot of people don't, they just say, let's use AI. To your point, Lisa, let's use AI when we're talking about utilization management. Well, what does that mean? How can it actually benefit us? At what cost? Who's going to decide? Who's providing the oversight? And what does it mean in terms of dollars, either saved or spent? So I think you know what the problem, identify the problem, you figure out what caveats you attach that are going to reflect your personal interest and needs, and then you develop and you actually execute a plan. It's pretty standard, but it requires that people be willing to take a step back and ask the hard questions. And I think there aren't enough people asking the hard questions about AI right now.
Right. That makes complete sense. And, so everybody kind of understands, where I come from as well is when I hear, let me give an example here, since this is on like the state level. If I hear New York saying, oh, well, we require validation protocols in place in terms of governance. And Kansas says, oh, we have to have an AI governance framework. My concern there would be where, okay, in New York, then you're only trying to fix a piece of a much larger, bigger puzzle here, and just having validation controls in place or requirements is not going to really push the AI deployments in a good direction in a secure and private way. So I was kind of looking for the consistency, consensus in that. But Tanya, to your point, I think it's not just the on the state level or an expertise challenge here. You have different complex entities within formulating the bills overall. So the next,
You do, Larry. If I could just jump in real quick
sure.
and piggyback on what you were saying, I think there are many different organizations across healthcare that are offering guidance, whether it's on the responsible use of AI or considerations for organizations. And they all take a different approach. So you're
Right.
right. There needs to be a specific focus on cybersecurity and compliance and what have you. But whether it's the Joint Commission or whether it's the National Quality Forum, whether it's specific organizations and healthcare systems that have the breadth of expertise and resources, a lot of people are attempting to make some advances in this space. I don't think we can wait until there's absolutely one. I mean, the White House has actually put out an AI action plan this summer. So there are many different routes that can be followed. And I think what's really important is that people step in, ask hard questions, and look to other experts because they know they don't have all the expertise themselves. And I think that's what we're trying to get people to understand today.
Well said, Tanya. Thank you. So my next question is: nearly every bill requires a human in the loop for medical necessity decisions, and provided facing laws mandate licensed professional reviews of AI-driven diagnostics and treatment recommendations. Some states, like Oklahoma, go further to require reporting whenever clinicians override an AI recommendation. I think it could be burdensome, or you could automate that, but it's a lot in my opinion. As again, somebody from cybersecurity having an audit trail, I get it, but it just seems like it could cause a huge burden than what really needs to be done. So the question is human in the loop necessary for every AI use case? And do you think reporting on clinical overrides are over the top, Lisa?
Yeah, so I think this is very similar to where we started this conversation, talking about utilization management. There's a lot of things that these amazing tools can do for us to create efficiencies, but when we talk about clinical outcomes, and we all work in the healthcare space, but all of us are also patients too, right? And
Right.
when you have some clinical need, you want to ensure that it's not just a data set that is determining the outcome, right? There's a lot of nuance in assessments, in atypical presentations that are really important to have a complete picture, a complete assessment. And so the automation might oversimplify it. It also might run into what we talked about, bias, right? If we're using training data, then I think there's certainly a risk of that. In the value-based care space, we have a lot of incentives, right? If we're just using AI tools, those incentives could be misaligned to against more complex, costly patients. And so I think for all of those reasons, at this stage of the game, yes, I think a human in the loop is really important to validate. Even if the AI tools are accurately, um, you know, providing that clinical guidance, whatever percentage of the time, I think that our current phase needs that validation, right? And perhaps in the future we can continue to advance that. But I think yes, the short answer, the short answer to my long answer is yes. Regarding the documentation,
Yeah.
I think Larry, your point about in cybersecurity, yes, we want auditable trails, and I think that level of transparency is really important. Tanya mentioned earlier, building trust when there's new technology is really important. And how do we do that? We have documentation to provide that. This is when this is why this happened. This is how we were able to make this decision either for or against the recommendation. I think it's a great intent, but I do think that as we as healthcare leaders define what's going to be really important to move into this phase of responsible AI adoption, I think we have to be really careful that we don't go swing too far the other way and expect additional documentation, right? Our
Right.
providers are already managing a daunting amount of documentation every shift, right? There's a reason the phrase pajama time exists, right? They're having to go home and document even after their shifts. Adding to that, I don't think is the best approach. So I think if that's something that feels really important, that might be a great activity for an AI QI team or a UR specialist that's doing some chart reviews. So I think where we place that task on the to-do list matters, as much as it matters the value of having that audit trail.
Right. And, I go back because I mentioned automation here to kind of help out with reporting on this, right? When there are clinical overrides. It sounds simple, everybody. Especially somebody like myself, would think it's, a flip of a switch or, some a few codes of line to write, within the AI application, but it's never that easy within the healthcare space. So, that's why I thought the question was really important. And Chris, I want to know what you think when we're talking in terms of clinical diagnostics and treatments using AI. Do you think having a human in the loop is necessary? And what do you think about clinical overrides having to report that every time that task is complete?
Yeah, I think it's a great question, and I agree with a lot of Lisa's points on this. And I think it's great in principle, but I think in practice, how is this going to happen? Right? We've talked about how clinicians are already busy in their clinics. How are they going to easily document that they overrode an AI? Like, did they push a button in the HR? Like, what do they do? Right? How are they going to do that? And so, to me, a smarter approach might be more of a risk tiered model where you have the human in loop or is much more involved in maybe assessing some of these decisions. So, for example, maybe for a higher risk clinical decision support, AI, like absolutely, right? This is essential for patient safety, right? Liability, maybe. But maybe for more administrative use cases like scheduling, maybe the AI, have a human in loop as much around something like that, for example. So, I mean, we want to be thoughtful about this so we don't actually if we're reviewing every output, we're paralyzing progress, right? So we have to be really thoughtful and think about doing this as a tiered approach. And as for the override reports, I mean, I just don't see how it's really possible to submit every one of these, to the state. I think it's onerous.
Yeah.
Organizations aren't going to adopt it for that exact reason, right? But at the same time, I understand it's important for drip. So maybe not mandating public reporting for everything, right? Because that could also create a lot of clinician hesitancy. But maybe this is where the organizational governance committees come into play, and it's their job to review some of these overrides and some of these outputs and make a decision about what needs to be reported. I mean, we do this now, right, for PHI and HIPAA and things like this. We have very competent people working in our organizations who could absolutely do this kind of work. And sometimes, again, somebody might override something. It's not really. It's nothing wrong with the AI. They could have another reason why they just decided to do it. Who knows, right? They accidentally click the button, right? These things happen all the time. So
Yeah.
I guess what I would say about this is really that, I think we don't need a human in the loop for everything, but we do need, we do need them in the loop watching the things that matter, is what I would say.
Right.
Yeah.
And just to let everybody know, the bill has failed in Oklahoma. So we're probably not the only ones thinking this. But yeah, just an
Yeah.
update
I'm sure there are a lot of
about that.
sighs of relief from that one for people.
Right, there you go, right? But it's, great. One of the reasons I wanted to bring it up so everybody can kind of see where, legislator heads are at. They can have an understanding of that. So kind of moving
And
on to
real
go
quick, Larry.
Sure.
I guess I just want to circle back on that topic one more time. The human in the loop requirement, I said yes. I'm talking about clinical decisions, assessments.
That's what we're talking about.
Like
Yeah.
Yeah. But like Chris said, more administrative things for sure. I don't think a human needs to be in the loop for things like that. So this one.
Absolutely. Thanks for updating us on that one. So the next topic we've been talking about from point in time approval to continuous oversight. This was a little bit eye opening to me because essentially we're talking about continuous improvement and monitoring of AI systems. And by nature, again, I always go back to cybersecurity. Continuous improvement is something that we do within the life cycle. There's never, leaving and said and done. So it was kind of odd. It was called out like this because it seems like it's just something that should be done. Let's not even talk about IT systems or IT just in operationals, any type of operations within healthcare or any industry for that. That there's always continuous improvement, right? So that's why I wanted to bring this to the light. So it's this idea of like shifting, to life cycle governance. Again, it isn't new. We always do this in cybersecurity and privacy. Continuous oversight, periodic reviews, KPIs, third parties come in to do assessments. So the question is, and we're going to start off with you on this one, Chris. Is this because lawmakers are coming from the perspective of insurance and healthcare regulation, which has historically been compliance driven and more static, meaning like annual filings, one-time approvals? Is this where this whole quote unquote new idea of continuous oversight is why it's looked at this way?
Yeah, I think so too. But I think to your point, I mean, it's, I go back to, are we just applying the old compliance models to new technology? And is this really the direction that we need to be going in? Even with the HRs, right, we have where they need to become certified. Those are typically, a point in time. They're not constantly always evolving them. But to
Right.
me, it's a little bit different with AI. It's so dynamic, and the models are constantly learning, like every
Right.
day, right? So if you do these annual filings, what are we missing, right? There's opportunities where things could evolve so much within 12 months. My gosh, I can't even think about. I think about what I'm doing with AI from a month ago, right? I mean, I mean, there's just every new day there's something new coming out. So, I think we do have to think about the life cycle oversight, maybe similar to some other areas, but I think that the challenge with this is really going to be around capacity too. I mean, I think just a lot of providers, but a lot of vendors. I mean, do people really have the capacity to really keep up with AI? So, and their audit team. So, I mean, this is almost where we're going to need other software to sort of help with the
More.
tracking, right? Auditing, right? We're going to have more products to be involved with auditing. But I don't know, is this where like you could have some sort of shared services or consortium models where states can have registries, together to try to look at some of this work together instead of submitting it to every single state? I feel like this is where we're going to have to really begin to think outside the box a little bit more. And what I think about is like, let's not treat AI governance as just a checkbox, but it really needs to be much more of a living process. Just like the data feeding it, basically, right? We need to sort of think about it a little bit differently.
Right. And
Yeah.
you're absolutely right. You made a lot of good points there. It's continuous, it's so dynamic that looking at this from an annual perspective, way too much can change within that time frame. I absolutely agree. And something else that you brought up is to actually do this. I think definitely continuous monitoring definitely should be done. Any systems, especially AI, is that healthcare systems are going to have to, start to realize that just like cybersecurity, it's going to take resources to do this stuff, and this needs to be thought of during the procurement process when you're deploying these systems. And it's not something we can just purchase to make the space better, which it will. But there's other things that come along with it to actually maintain it and make sure that it's safe ultimately
Yeah.
for the patient, right? So now this is a really, really fun part. That stuff is very interesting to me, but this is very, very fun because we really start getting into the technical stuff, and we're going to start talking about training and design requirements. Very interesting bills introduced. First, we'll start off with Oklahoma. So Oklahoma introduced a bill that said an insurer shall submit the artificial intelligence based algorithms and training data sets that are being used or will be used in the utilization review process to the Department for Treasury. I couldn't imagine the chaos that would cause, and the people on the state level who actually have to review that stuff. But is this over the top, Lisa?
So, I think the request itself, the intent of the request is reasonable, right? What are they really asking for? They're asking for transparency.
Right.
But then what? Right? So we submit this data set, these models. Who reviews it? What's the process for that? And so I think it's a little bit cart before the horse.
Right.
I think that, Chris, not just like you said, not just checking a box. Yes, we have them. They're filed somewhere. No one's reviewed them. So I think we need to be very intentional about, as we're defining these processes and governance, what things do we need to review? How do we actually review it? Who needs to review it? The frequency matters, right? That we just talked about that. It's changing so fast. I think beyond that, when you're talking about different tools, there are going to be there's going to be IP. There's that people aren't going to want to
Right.
share every element of it. There's
That's
going to be
my concern.
patient
Yeah.
data, right? So then we have to think about how do we manage patient data and keep that private, because so do we redact all of it, right? So I think I have a lot more questions than I do answers about this.
As you
But
should.
right. So I think we need to define it quite a bit more clearly before we would try to pass something like this.
Right, absolutely. And what do you think, Tanya? Submitting algorithms and training data to state on the state level, is this over the top?
Yes. And we'll just leave it there. I think we all get it.
Yeah.
To Lisa's point, I understand the intent, and I think that's admirable. I thought it was interesting, Larry, that of all of the states that indicated a desire to move toward governance, Oklahoma was the only one who actually codified some type of governance structure. Now, they may have over codified or overreached in that codification, what have you. But I think they're making an attempt to move. And I think that's one of the things that we have to recognize. The entire country realizes that AI is here. It's having an impact. It is going to continue to have an impact. And we need to get on board and understand it and be involved. We can't just let it happen to us at whatever level of stakeholder one is. So I give all of the states credit there. I do think that as a vendor, you're not going to find any for-profit vendor who says, sure, take my algorithm, and I'm sure you have all the expertise needed to comb through it, understand it, ask the right questions, and oh, by the way, protect it from anyone else who might be wanting to take a look at it. So
Yeah.
that's how I would answer that question.
Yeah. I want to just add to that. I agree with both. Even spinning off on the vendor side, I mean, do the states want to take that risk of having intellectual property like that, where that could get hacked into and then they're liable for, releasing, something proprietary for a company too. So I think there's a lot to think about there. But the other thing I did want to say on this too, which I really did like the spirit of how they explicitly addressed issues around discriminatory unsafe practices and making sure that they wanted to make sure that things were like not the algorithms were not looking at things based on age or race, right? And unduly biasing things or disabilities. I also liked how they were things needed to strictly adhere to clinical guidance. So like the thought around that, the spirit around the intent around that, I think was really well thought out and advanced in some compared to some of the stuff that we've seen so far. So I think, again, I think, people are putting a lot out there just to see what sticks. But I like that, I like being explicit in those areas, right? Because if we're not explicit, that leads to interpretation and people could say like, oh, I didn't know that we had to do that. Like, I didn't know that we had to make sure we weren't biased against race or age or whatever, disability, whatever it is, right? So I do like that, that part being very explicit in some of these regulations. I feel like we shouldn't have to be, but we do. There we are. This is where we are.
You absolutely have to be. And I'm gonna piggyback off you and Tanya. Yeah, absolutely. I like that the states are headed in the right directions. They're actually considering and thinking about this because governance is important. But yeah, my opinion, it's way over the top, and that's probably why the bill failed. So, but I'll leave it at that. On to another one. This one's very interesting. In New York, on or before January 1st, 2026, the developer or a health tech company of a generative artificial intelligence model or service shall post on the developer's website documentation regarding the data used by the developer to train the model or the service. And this includes the source or owners of the data sets, a description of how the data sets further the intended purposes of the model, and the number of data points included in the data sets as well. And this bill has been passed. Chris, what do you think about that?
Yeah, it's interesting, right? Because I think New York is really trying to like strike more of that balance too, as well, about having public facing, summaries and data sets without completely exposing proprietary information. So, for healthcare, like transparency doesn't always mean for the vendor to open up their code database, right? And for the world to see. I mean, what it is about is clear documentation, about validation. It's about how it's intended to use. It's about showing organizations how they can evaluate risk and bias within, their organizations when they're using this. So I really think, but the other thing I think about this is, which is also really important, is that, as somebody who's worked in technology, like we, either intentional or unintentional, you put things out there and it's not always digestible by the human average person. Like I could put something out there and somebody who's not, a technology person might like, I have no idea what you're saying, right? In these summaries or whatever this means. So I think we also have to be very careful to make sure that whatever we're putting out there for, like the average person is digestible, it's understandable, right? So people really know what's going on. We're not making it so high and so sophisticated that, people can't sort of read this and make their own determinations around what's going on. It's almost like, we think about like health literacy sometimes. We think about materials needing to be at a certain grade level. I'm thinking about this as the same way. Like, should the materials be at a certain, literacy grade level, so people can really understand it and how it applies to within their organization. So it's like transparency doesn't mean just open source, right? It means accountability. It means literacy as well.
Right. Absolutely. Really quick, 30 seconds. Did anybody else want to weigh in on this?
I
Okay.
think I say I agree, spot on. I don't have anything
Yeah.
very different to add.
Yeah, I'm going to give my 2 cents here. Pasting your information on your website, data sets, the model that you use, all of this stuff is like opening up a can of worms. Essentially, you're putting all your IP on your website. Tech already, I love it to death, but already is, let's call it what it is. It's copycat, right? Everything is open source. Now you're putting your AI models, it's information on your websites. It's just, making it even worse. I think this is really over the top. I can't believe it passed in New York, but that was very eye opening as well. So moving on to safety and security protocols. So in North Carolina, a license shall conduct. I'm sorry. So an entity shall conduct regular inspections and perform annual third-party audits. Results of all inspections and audits must be available to the department, aka the state, and they should conduct these regular security assessments no less than every 6 months and report breaches within 24 hours to the Department of Justice and 48 hours to affected consumers. Whoa. What are your thoughts on this? Who do I want on this? Lisa, what are your thoughts on this?
Well, again, I think going back to the intent, right? We want it to be safe. We want to have a mechanism for reporting and notification in the case of a breach. I do think, though, we have to be more reasonable in the timeline. I think in any breach, the first action should be to contain it, to manage the risk, right, and mitigate the risk as much as you can. The reporting, while important, I think suggesting that it's going to be done within 24 hours, 48 hours, I think that's unreasonable.
Right.
And so I think that it would be, it would be much more beneficial to us to have something that the timeline was more reasonable.
Right. Absolutely. Tanya, 30 seconds. Anything to add?
I think establishing guidelines or principles by which a state or a healthcare organization can follow is really important, because then these slight variances are going to make themselves more apparent. And I think not enough folks kind of have that true north right now in terms of what they want to do with their AI strategy.
Great,
Yeah, I was
great.
gonna.
Chris, what are your thoughts? Somebody who's
I
always
was
like
thinking,
really, really
yeah, I was
interested.
thinking we're worried about AI taking jobs, but I'm like reading all these new policies coming out and thinking we're going to be creating lots of jobs to be auditing AI. Like I see a whole new marketplace, a whole new type of job emerging here. So listen, I think the spirit of the law is right. I think continuous marketing, third party auditing is correct. I mean, we're doing it with the FDA, things that are used in medical devices, medications, right? We need to protect people. So there are certain types of AI use that I actually think we need to have this in there in the monitoring. I think the third party audits are correct. I think most organizations, most vendors are going to come out with good intentions, but we do have to make sure that we're protecting people in that way. I also think about this too, as somebody who's a small business owner myself, is that we want to make sure that we're also not putting too much burden on smaller organizations, and that for a bigger organization, this is a blip in the road, or it's not as much for them to sort of deal with this. But I want to sort of also be thoughtful about not stifling some of the innovation that's out there along the way. So again, I think we just need to have security that's right sized. We know it's not a one size fits all, right? So that's how I would think about it.
Yeah, absolutely. My thoughts. I love the third party audits. It really holds people accountable a lot more than doing a self audit. I think that every 6 months, is very aggressive, very very aggressive. Maybe perhaps something you have something. They could use something. Whatever reporting you're doing for your continuous monitoring strategy, maybe they can should consider that to monitor during the interim and require, annual audits. But 6 months is going to be costly and very tough. Like right now, it takes just to do a SOC 2 audit, it takes at least 6 to 8 months just to do that. And you have to do that once a year. So could you imagine the resources and constraints to do this twice a year? The reporting time frames, to your point, Lisa, I think they're a bit aggressive too. 24 hours. First, you have to really understand what was taken. Is it really a breach? That sort of thing. And that's, of course, it's going to take, longer than 24 hours. So I think those time frames should be extended, but a little bit more conservative than, I think that we're seeing now with HIPAA. So it definitely should be quicker than that. One more we're going to talk about, because we're running up on time, and I have two more things I want to get your opinions on. So we'll talk about one more bill here, and this is mandatory patient notification when using AI in coverage or care decisions. So in Texas, the bill was passed, and the requirement is a healthcare practitioner who uses AI for diagnostic purposes, as described by whatever subsection in the legislation, must disclose that the practitioner's use of that technology to the practitioner's patient. So if you're using, in Texas, if you're using AI for coverage of care decisions, you need to notify the patients when it's being used. Does this make sense, Lisa?
So this bill is a really interesting one.
Okay.
And they bundled a lot in there.
Okay.
268 pages, by the way.
Wow.
Yeah. It had very little language related to what we're discussing. It was a bit of a circular situation that I was led down this path, that path. So they put some very basic conditions that said if a practitioner is using AI, they need to practice within their scope. Okay, that seems reasonable.
Yeah.
If they're using AI, that AI should not be restricted or prohibited by the state or federal law. Okay. And then they also should document in a manner consistent with the Texas Medical Board. However, the Texas Medical Board does not have any language specific to AI and documentation. So it led me to another act, the Texas Responsible Artificial Intelligence Governance Act, or TRIGA. Again, most of the language is very general and not specific to healthcare. There was one point about 6 or 7 down that just said that the provider is responsible to notify the patient on the data service that the treatment's provided, unless it's a case of emergency, then as soon as possible. So a lot of words for very little direction or guidance is the takeaway.
Got it. Thank you. And Tanya, what are your thoughts?
So I think this places a lot of burden on providers who they themselves may not even be aware that they're using AI. And if they are aware, they may not be aware of it and able to communicate that to the patient in a way that's understandable. So I place a lot of the burden on the vendors to providing the documentation that then can be used by the healthcare organizations and their very, very expertise deep legal departments to come up with a general statement. Healthcare organizations have patients' bill of rights. You can have a general statement. I'm not going to offer one up. I am not legally trained, but you could have a statement that indicates the use of AI. And if you have questions, this is where you go, in the same way that the rest of patients' rights are covered. There are always going to be patients who have deeper questions. You will have someone who can answer them, and then you can meet both the letter and the intent of the law.
Maybe have AI answer them.
Yeah, exactly.
Right. Okay. The last thing, we're right on time here. The last thing I was very, something else that I loved about this report is enforcement, and why, it really, I guess, is dear to my heart, is because with HIPAA, I think penalties are minimal. I think that's one of the reasons why, we keep seeing these breaches, because institutions, cover entities or business associates to say, well, we're doing well. We'll take the risk. We'll pay the fine because it's minimum, that sort of thing. So what we see here is most states are going with moderate penalties, 1K to $50,000 per violation. That's much more than HIPAA. So my question is this enough?
Mm.
$1,000
Yeah,
to $50,000 for a violation? Is this enough to thwart it?
I saw this and I thought to myself, like, again, back to that imbalance, right? For a large payer or vendor, like, to me, this is just like a rounding up exercise for them, right? Not a real deterrent. They're like, we'll pay it, we'll move on, whatever, right? So I think and then you also have to balance this against potentially having frivolous suits too, right? So I think there's do we need to, maybe it's something more lines of a data breach law where reinforcement is based on systematic or repeated violation or intentional or demonstrative harm, right? So I mean, I think again, the goal is not punishment, right? It's just about transparency, documentation, accuracy, governance. I mean, that's really where we want to get to around a lot of this work. So I don't know, if what the exact way to go here is, but I think accountability should sting enough to matter. Let's put it that
Right.
way, and be a deterrent, but not enough to stall progress too. So I think we don't want people to dive in and who are afraid to actually build some great tools that could really impact, patient care, provider productivity, all those kinds of things. So I think we need to balance that there.
Really quick, 30 seconds. What are your thoughts, Tanya?
Nothing new to add. We'll keep it that way.
Got it. Lisa?
Same.
Got it. So this is real interesting. What do you think about? And by the way, even with the 1K and $50,000 per violation, I think this is an idea. I don't think it's solidified yet. But this is something else that is an idea. Is individuals having the right to sue outside of regulatory action. Do you think this is a good idea, Tanya?
Well, I think that
Yeah.
patients have the right to sue now, outside of regulatory guidelines. So I don't know that I would want to encourage it, but I do think that it understates the importance of transparency and trust building across all of these different groups. So I don't want people willy-nilly, going out there and suing healthcare organizations because there was a mistake made that perhaps was an administrative mistake, not a clinical mistake. And I think those differences are important.
That is
But I think that's why the organizations that are moving in the right direction have to become more specific. And I think if there is one takeaway that I see from this conversation, it's that a lot of organizations, a lot of states are trying to pass laws to move in a direction, but they're still only taking baby steps. So,
right. Lisa?
I think and I guess I'm going to just comment on what Tanya just said. I think because this landscape is changing so quickly, some of the bills that were in this report that did not make it was because maybe it was too much of a reach. And some that passed maybe were a little bit too skinny, but we have to
Right.
start somewhere. And so I do think that progress is important. And I think, while consumers, patients should potentially have the same recourse they have in healthcare now, I think the bigger opportunity is to, build practices and policies that do reduce the risks, build trust, that reduces that reflexive intention to use the legal system in that way.
And Chris, what are your thoughts on this?
Yeah, I mean, I think the same thing. I mean, I think feels very tricky around a lot of this, but I think if there's like obvious neglect or harm or failure on somebody's part, I mean, there always has to be accountability around that, but I think we also don't want to create a situation where there's a lot of unnecessary neglect. But to me, it's like I think about this as transparency is really the foundation of all this work for me. And that's really around, it's going to drive the accountability. And the whole goal about this is the accountability drives better outcomes, right? So I think that's really what we're about at this point in time. And, I think that, we're still in the early innings of this. We got the playoffs, baseball playoffs going on. So we use the baseball analogy. We're still in the early innings of all this work, but it's going to be important for the states to get this right and really strike that balance between developing both that allowing for that innovation, but also keeping with transparency and trust too.
Right. Thank you. I appreciate that. And what I think patients should have the right. I think it's kind of tricky on what. And one of the reasons I say that is because what I keep seeing now with HIPAA is there's this huge right to access issue where patients aren't getting their information when they request it. And I see OCR coming in very often, too often, and finding health systems because they're not providing patients with their information. So I think, when it comes like something like that, to me is very serious. I should be able to request my information and, not wait a year to get it, that sort of thing. So I think it should be categories on what they consume, what's very important to the patient to kind of thwart that. That's where I'm at. But yeah, all very interesting. And, we are a little bit over, but I want to thank everybody for, watching. If you have any questions, please reach out to Chris, Tanya, Lisa, or myself. We'd be happy to answer them. But I want to be respectful of everybody's time. Chris, Tanya, and Lisa, this was a lot of fun. I can't wait. Can't wait to do it when version 2.0 comes out again.
Yeah.
So thanks for joining, and I hope everybody enjoyed this.
Great. Thanks so
Thanks,
much,
everyone.
Larry. Thanks, Tanya. Thanks, Lisa.